Welcome to the first of two lectures on the hematopoietic system. This lecture will focus on anemias. In this lecture, we will differentiate among microcytic, normocytic, and macrocytic anemias, and we'll talk about examples of each. We will talk about the age and genetic influences on the development of anemia, and we'll use laboratory test results to help us determine the physiology and the etiology of the different anemias. So let's start with sort of an overview and some basic concepts about anemia. A clinical definition of anemia is a reduced red blood cell count, hemoglobin, and hematocrit. Now remember that physiologically we need red blood cells. We need them for oxygenation. We need them for carbon dioxide removal. They're part of our buffer system, so they participate in our acid-base balance, and they also assist as scavengers of oxygen-free radicals. And of course that's because they carry the oxygen. One of the most important things that we always want to remember about anemia is that it's often a symptom as well as a diagnosis. As a result, then, when you see anemia, it is not normal. It's important that we look for the reason for the anemia. We know that speed of development matters, and we know that hemoglobin changes. The level of hemoglobin changes as we mature, and we also know that the level of anemia affects our ability to dissociate oxygen. So let's go back over those each of those. That sounded odd. So first off, speed of development. Absolutely that matters. In general, if we have time, if the organism has time to compensate for the anemia, they will not become physiologically unstable initially. So as a result, there really isn't any magic number that tells you when the symptoms will occur. However, once the hemoglobin drops 4 to 5 grams, you begin to see failure of homeostasis. However, this is going to vary by individual. So for example, let's say that you have someone with severe cardiovascular disease and has a lot of trouble with coronary artery circulation. Well, that individual may not be able to homeostatically withstand a 4 or a 5 gram drop in the hemoglobin before they start developing symptoms of breathlessness and fatigue, because they need that oxygen that isn't being delivered effectively to their heart muscle. So they have chest pain when they have what would mostly be considered in many individuals as a minor drop in their hemoglobin level. As we talk about speed, we also think about an acute blood loss versus a blood loss that occurs over months, maybe never not years, but generally over months. Again, the longer it takes that anemia to develop, the longer the organism has to homeostatically adapt to it, and so as a result you don't see big hits on homeostasis. Now, when we think about how hemoglobin changes as we mature, we kind of think about the level of hemoglobin. So if we look at the average adult, in a female, an average hemoglobin is right around 14. Yes, there's a range, but I can remember 14. In a male, so female about 14, in a male it tends to be about 15. So males tend to have a slightly higher normal hemoglobin than females. Now, when we are born, our hemoglobin is closer to 20. And that makes sense because the developing fetus develops in a relatively hypoxic environment. Therefore, it makes sense that they would have more red blood cells in that relatively hypoxic environment to carry the oxygen as they're developing. Within about 2 weeks of life, the hemoglobin begins to drop and generally drops down to about 15 or 16, and by the time the baby is about 6 months old, the hemoglobin may normally be down around 11 or 12. Then from that point up, the hemoglobin begins a slow and steady rise until most kids will approach those adult values right around 10 years. Now, as I mentioned earlier, there's an important concept called the oxygen dissociation curve. So as we look at this, when you look at the curve, with anemia, the dissociation curve shifts to the right. What this means is that with anemia, this allows oxygen to unload from the red blood cell or from the hemoglobin more readily. As a result, this results in less dramatic or abrupt symptoms and signs. One of the things that we really watch for as one of the signs of anemia when it's developing is an elevation in the heart rate. So if this has been a slow shift to the right, the heart rate may not increase a lot as a compensatory mechanism. If it's been a rapid or acute blood loss, then you're going to see the heart compensatory mechanism, tachycardia, kick in a lot more quickly or be more significant. So then why would someone become anemic? Well, as we look at why someone would become anemic, let's look at three major areas of why. There could be a decrease in the production of red blood cells. There could be an absolute loss of red blood cells, or those red blood cells that are being produced are defective and as a result aren't doing their job as well. So as we think about decreased production of red cells, there's some important things to think about. One, erythropoietin. Erythropoietin is the primary stimulus to the bone marrow to produce red blood cells. Anoxia is a very poor secondary or even tertiary stimulus for the bone marrow. 90% of the erythropoietin, the hormone, is produced by the kidneys. About 10% comes from the liver. What about nutrient deficiencies? Certainly iron is important. Iron is a major component of making hemoglobin. Hemoglobin makes up the majority of the mass of the red blood cell. So if the iron nutrient is deficient, either because it isn't in the diet or it isn't being absorbed in the diet, then the individual would not be able to produce sufficient or healthy red blood cells. Folate and vitamin B12 are also essential nutrients for the production of red blood cells. Now, additional nutrients that we need to think about include some of our trace minerals. These include cobalt and copper. Comorbid conditions are important. Certainly, a decreased production of red blood cells would be seen in someone who has a lot of bone marrow dysfunction, someone with leukemia, whose bone marrow is more interested in producing defective white cells rather than anything else. And then, of course, inflammation and the inflammatory state. You just can't run from inflammation. We're going to talk a little bit more about that in a second. So what about the loss of red blood cells? Again, absolute blood loss. This can be chronic blood loss, like through a slow GI bleed, a colon cancer, or it could be an acute blood loss, like a trauma. And again, it's all about adaptation when you start thinking about symptoms. Hemolysis. Hemolysis could be due to disease processes or something in the body. So something in the body. We used to put in old metal mechanical heart valves, and those heart valves hemolyzed red blood cells. If you have someone with an implantable implanted pump for heart failure, those pumps cause some level of red blood cell hemolysis. What about shortened lifespan? Well, we know that the average normal lifespan for a red blood cell is about 120 days. Disease processes can shorten that lifespan. Any chronic inflammatory disease can shorten red blood cell lifespan. You're not going to be surprised that I'm going to mention kidneys. When individuals have failing kidneys, as they become increasingly uremic, their anemia tends to worsen. Now, part of that is because their kidneys aren't producing the erythropoietin, but so it's a decreased production, but the other side of that is that the uremic environment shortens the red blood cell lifespan. And then also the third bucket is that an individual may be anemic because the red cells that they are producing are defective. Frequently, this is due to a genetic defect, and the two that we will talk about are sickle cell disease and thalassemia. Last but not least, I think we want to remember that in our physiology, in a normal red blood cell and in normal physiology, 90% of our red blood cells are phagocytized. And when we phagocytize our red blood cells, and actually this is whether this normal or abnormal breakdown, iron from that red blood cell goes into storage. The primary storage site is the liver. About 10% of those are, instead of being phagocytized, are actually broken down or hemolyzed, and then they're removed by the immune system. We also need to recall that the spleen plays a major role in the sequestration and the removal of broken down red blood cells. So I promised, okay, maybe threatened, that we would talk again about inflammation and infection. This is a very important concept because the inflammatory cytokines have major effects on, potential effects on anemia. One of the effects is that the inflammatory cytokines, and these would be the pro-inflammatory cytokines, inhibit erythropoietin production. Therefore, the poiesis, or the production of red cells, would also be inhibited. Inflammatory cytokines also have the ability and do destroy immature erythroblasts. So if you're destroying the immature erythroblasts, the immature red blood cells, obviously they can't mature and someone would become anemic. The third thing that inflammatory cytokines do is they stimulate the release of hepcidin. Hepcidin is a substance that blocks the release of iron from the reticuloendothelial system. So because those inflammatory cytokines are stimulating the hepcidin, and the hepcidin is out there, you're not able to release the iron from the reticuloendothelial system. Therefore, iron isn't available to make the hemoglobin. If you can't make the hemoglobin, if you're not able to make enough hemoglobin or healthy hemoglobin, then that would result in an anemia. The second thing that hepcidin does is it actually decreases the absorption of iron that is taken in through the GI tract. Finally, it's important to remember on the infection side is that iron is a growth factor for bacteria. Now, iron is a trace element that bacteria and other organisms are also going to use, but we really think a lot about it in terms of bacteria. So that there is something of a, I will say, it's not a controversy exactly, it's sort of a discussion about if someone needs iron repletion and they are acutely infected, should you wait until you've got the bacterial infection under control before you start aggressive iron repletion? The idea there is because iron is a growth factor for bacteria, if you give a lot of iron, yes, you're treating the anemia, but the bacteria may use it before the red cells are able to use it. Bacteria produce and replicate more rapidly than the red cells do. So you can see why there's some conversation about that. So as we have that as something of a background, let's look at markers for anemia. And these are physiologic markers, and we use this in our diagnostic workup. We'll look at the red blood cells and their indices. We'll discuss these shortly. Certainly, we want to look at hemoglobin and hematocrit. Remembering that the hemoglobin is what carries the iron. You need the iron to make the hemoglobin. Hemoglobin makes up a lot of the red blood cell mass. Hematocrit just sort of tells you a percentage of the red cells within the circulation, or within the serum. We also want to look at the reticulocyte count. Reticulocytes are immature cells. We would want to take a look at iron parameters, including the iron level, ferritin, transferrin, and the iron binding capacity. It's important to remember that all of these are pieces that we do when we are looking at an anemia workup. We should also take a look at white blood cells and platelets to make sure that those are being produced, because what if they have a pancytopenia, meaning all of the cells from the bone marrow are being affected. And the last but not least, we want to look at the presence of occult blood. This is primarily in the GI tract. And again, frequently we'll see this not only in acute GI bleed, that would be pretty easy to see, but certainly someone who has a chronic GI bleed, or the chronic removal of blood through the GI tract, like in a colon cancer, something of that nature, we would want to be checking for occult blood. There's another thing that I thought I'd give you a quick trick about, and that is the hematocrit. This is a real quick trick to use the H&H, the hemoglobin, and the hematocrit to check fluid status. If you take the individual's hemoglobin and you multiply it by 3, it should be a rough estimate of their hematocrit. If that number is greater than expected, the individual is volume contracted. If that product is lower than expected, the individual is volume expanded. It's one of those tricks you can use in your practice. Before we talk about absolute pathologies, let's talk about some variations in normal hemoglobin, because these are things you need to take into consideration as you are distinguishing between physiologic variation versus pathology. One of the variations is altitude. As you go above sea level, the level of hemoglobin will increase. So the hemoglobin will increase approximately 0.6 grams per deciliter in women and 0.9 grams per deciliter in males for every 1,000 meters above sea level. So let's think about that for just a second. This is why athletes train, like in Colorado Springs, so the Olympic training facility. One of the reasons it's there, it's because of the elevation above sea level. Because as they train in a higher elevation, doesn't have to be Colorado Springs, any place that has a higher elevation, over time, they will have an increased production of hemoglobin, therefore red blood cells, and they improve their oxygen carrying power. So what about age? In men, as they approach their 70s, mid-70s and onward, the hemoglobin level tends to decline a little bit. In general, remember that a declining hemoglobin with aging is a reflection of poor health. It's not a normal variant of aging. So then why does the hemoglobin tend to decline a little bit in men? Well, that's because as men get older, they have fewer androgens as they age. Androgens are play an important role in red blood cell production. And so as men get older, they have fewer androgens, and so you might see a little bit of decline for that. We've actually used androgen therapy in some men to treat anemia. Last but not least, anemias in elders are more likely to be overlooked. And part of this is because people say, okay, well, this is just a normal part of aging. Once again, I cannot say this enough. It is not. Anemia is not a normal aging. Now, I know we talked about a slight decline in men, but that doesn't mean they've reached frank anemia. One of the reasons it's easily overlooked is because some of the symptoms that they may have, fatigue, weakness, maybe a little bit of shortness of breath. Some of those may be masked by other comorbid conditions, or their symptoms are attributed to those comorbid conditions rather than an anemia that is developing. So as you work with elders, just kind of keep that in mind as you do your symptom review. One of the other things is we talked about changes in the level of hemoglobin, but as far as that physiologic change, we know that when the fetus transitions, when the baby transitions from fetal to extrauterine life, there are physiologic changes that have to happen. Now, we talked about this idea of fetal life being they essentially have a relative polycythemia because of that low oxygen environment. They produce more red blood cells. That's why when they're first born, they have a higher hemoglobin. At birth, that rate then would decrease, and the number of reticulocytes also decreases, and the rate of red blood cell destruction increases because they just don't need as many. Now, what happens then with this red blood cell destruction is that there would be a release of bilirubin because they're destroying those red blood cells. With that destruction of bilirubin, now that bilirubin has to be processed. The bilirubin is processed by the liver, but at birth, even though they're breaking down the red blood cells and that bilirubin is being released, now it goes to the liver, but the liver is immature. And as a result, the liver can't fully process that. This is why we see the jaundice, the newborn jaundice. This is physiologic newborn jaundice. Now, don't confuse that, however, with hemolytic disease of the newborn, which you'll see with an ABO or an RH incompatibility. Hemolytic disease of the newborn is not physiologic. What happens there is you have an even higher rate of hemolysis, so more and more and more bilirubin is being produced that the immature liver cannot process or manage. High levels of bilirubin are very toxic to the central nervous system and causes a CNS damage called kernicterus. Now, as I always try to do, give you something that you may not know. Those of you that have worked with kids in the newborn nursery, what's the therapy that we use to help conjugate that bilirubin so that it can be released when the baby has newborn jaundice? Yeah, we use light therapy. Did you know that light therapy, that idea and implementation of light therapy in decreasing newborn jaundice was noted first by a nurse in England? She used to take her babies outside in the sunlight and she noticed that it helped with their jaundice. Pretty cool, huh? Other variations that we want to be aware of include race and smoking. African American individuals tend to have a slightly lower hemoglobin, and you can see that there, than white or Asian individuals. I've not seen the information related to Hispanics, so I can't share that information. What that means then is the symptoms of anemia and an anemia may occur a little bit earlier in an African American individual than someone who has a white or an Asian background. In smoking, we know that smoking is associated with increased levels of carboxyhemoglobin. Carboxyhemoglobin is less functional than normal hemoglobin. When there's an increased level of carboxyhemoglobin, that then leads to a compensatory increase in hemoglobin in general. Now that sounds like a great idea, right? Because you don't want the carboxyhemoglobin because it doesn't function as well. So if that makes us compensate by putting out more hemoglobin, that's a good thing. It is a good thing. However, smoking is also pro-inflammatory. So when someone is a chronic smoker, They are in a pro-inflammatory state. And remember, we talked about just a little bit ago about the negative effects of the pro-inflammatory cytokines on the development of red blood cells. Okay, so with a sense of some normals and some of those variations that aren't true pathologies but can become pathological, let's talk about anemias themselves. So I wanted you to see some cells. So I'm going to see. So this cell, this little guy here, that's a red blood cell. Unfortunately, it's not really white. It's going to be red. See that biconcave disc with a little depression? Normal red blood cell. This little knobby-looking guy is a white blood cell. And this odd-looking thing is actually a platelet. So let's talk about those indices that I mentioned earlier. Red blood cell indices are extremely helpful in helping us define the type of anemia that an individual has and are frequently calculated values. The indices that we're going to talk about include the mean corpuscular volume, we're going to use that a lot, the mean corpuscular hemoglobin concentration, and the red cell distribution width. Of the three, the one that we'll use the most is the MCV. The MCV tells us about the average size of the red blood cell. And so this is a calculated value, and they get it by dividing the hematocrit by the red blood cell count. Since we're looking at size, then we're going to look at microcytic, normocytic, and macrocytic as describing the volume of the corpuscle. Now, and we're going to use this all the way through. What's important is that very frequently the mean corpuscular volume will decrease on your labs before the mean corpuscular hemoglobin concentration in an evolving iron deficiency anemia. So what that means, so the importance there is, even though we would look at both the MCV and the MCHC, we know that the measurement of the volume tends to decrease before the hemoglobin concentration does, and so it is an earlier sign. We also know that the MCV can be affected by other things. It can be affected by hyperglycemia. So the volume of the red blood cell is increased in a hyperglycemic state. And part of this is because fluid is moving into the intracellular space. You will also see an increase in the volume after 8 hours if the blood has been stored at room temperature for about 8 hours, or even 24 hours if it's been refrigerated. That's why you need to know a little bit about specimen storage in your labs when you look at lab work, because it can affect your lab results. And once again, why do those cells get bigger? Because the fluid moved in. So as a result then, if you have someone who has a hyperglycemia, or who has a bad storage, the blood has been stored very badly in the lab, you can actually see a false increase of their hematocrit of 2 to 4% when they have an inappropriately elevated MCV. That's why we don't intervene solely on the basis of a hematocrit, because it'll change the hemoglobin, or the crit. So MCHC is the mean corpuscular hemoglobin concentration. So this is the amount of hemoglobin in the red cell compared to size. You can see and we do that by dividing the hemoglobin by the hematocrit, but it's the amount of hemoglobin in the red cell compared to the size of the red cell. Now, this will decrease before the MCV if they have an evolving anemia of chronic illness. So now you've got two differences in how you can use these indices. As we talked about it, the MCV will decrease before the MCHC in an evolving iron deficiency anemia, but the MCHC will decrease before the MCV if they have an evolving anemia of chronic illness. Now, we use the MCHC in our overall classification and description of anemia as well. This is where we use, this is what tells, because it's the hemoglobin concentration, this is what tells us something about the color of the red blood cell. So if they have a low MCHC, they would be hypochromic. If they have a very high MCHC, they would be hyperchromic, or if it's within normal limits, they would be normochromic. So as a result, then, you could have a microcytic hypochromic anemia, or a normocytic normochromic anemia. You can play with all of those. Another one of our indices is the red cell distribution width. This tells us about the variability of the size of the red blood cell. A normal value indicates that most of the cells are about the same size. You'll see a greater variability in iron, B12, and folate deficiency anemias. So again, you're not talking about an absolute number, but you're looking at whether or not there's a lot of variability in the width of that red blood cell. RDW is very helpful in a hemolytic anemia because you'll have a lot more variation of the size of the red cells in a hemolytic anemia. When that RDW, the distribution width, is greater than 15%, it tells you that you have a lot of new red blood cells forming. And when you have a lot of new red blood cells forming, you've got more variability or variation in the size of the cells themselves. We can also take a look at the reticulocytes. Reticulocytes are immature red blood cells. Reticulocytes are larger cells than mature cells. If you remember from your normal physiology 400 years ago, remember that red blood cells actually mature in the circulation. As they become mature in the circulation, they become more iron dependent and they become a little bit smaller as they undergo maturation. As a result, then, we can look at the percentage of reticulocytes in the circulation. When we look at that percentage, it tells us how many may have not matured after they have been released, or it will also tell us whether the bone marrow is dumping a lot of immature cells into the circulation and they're not able to mature fast enough. So when you look at the reticulocyte count, remember that you're looking at a percentage, and you're looking at the percentage of those immature red blood cells that are supposed to be maturing after they've been released. If that is a high percentage, you should be considering why they haven't matured after they've been released, or is the bone marrow dumping a lot into the circulation and they're just not able to mature fast enough, so you've just got a lot out there. Now, you can also do an absolute reticulocyte count. I'm not going to spend a lot of time here because I think we use the reticulocytes a little bit more, but that absolute count tells us more about the proliferation and the bone marrow response. And we can actually use that to identify other parameters. This is what a hematologist really gets into. For our purposes, I want you to have the core concept of reticulocytes and the importance of not having too many in the circulation. Now, there's also a variety of ways to actually describe those red cells. We talked about their size, microcytic, normocytic, macrocytic. We talked about their color, normochromic, hypochromic, hyperchromic, but there are also additional ways of describing what these cells actually look like. So forgive me for a little bit, we're going to play a little bit of definitional and name that term, because you'll see this on your complete blood count lab work, and I really want you to start paying attention to those, because when you see these words now, you're going to know exactly what they're talking about. So when you see it, when it says anisocytosis, it means that there are a lot of different sized cells out there. That's all it means is anisocytosis. Basophilic stippling is indicative of lead poisoning, and it's a characteristic appearance of these red cells under the microscope. If you see that they have sideroblasts, it tells you that the individual lacks an enzyme, one of the enzymes to make heme completely. This is this then results in an abnormal molecule, and it makes their cells look different, and they call those sideroblasts. You may also see spherocytes and schistocytes. These are red blood cell fragments. So when you think about red blood cell fragments, you should be thinking about a lysis. So could this be a mechanical heart valve? Not those manufactured ones, but one of those old mechanical light valves. But something that's causing those red blood cells to fragment. Someone who has an implantable pump. And poikilocytosis. Poikilocytosis means that they have a number of tear-shaped cells. And you look for this in a B12 or a folate deficiency. So what would those actually look like? Well, certainly these have, you can see here, a representation of anisocytosis, because you've got a lot of differently sized cells, don't you? You also have poikilocytosis because they're differently shaped. See those guys? Those two, poikilocytes. Now, I also included this as a handout for you to download, because this is a great way to help you focus your thinking and also to differentiate the anemias by their mean corpuscular volume: microcytic, normocytic, and macrocytic. There is also a great table in your text, and it's table 29.2. Great table. I encourage you to take a look at that. But I hope this will help get you started. So one of the things that we always want to then start putting that together is, let's use this information real quick. Normal, abnormal. So as you can see, these cells tend to be a little bit smaller. A lot of them are a little bit smaller, and they are certainly paler than these guys are. Normal, not normal. They're bigger, aren't they? And they also have target cells. Target cells are abnormal cells. Those are called target cells. They kind of look like targets, don't they? I just want to have you get a sense of what everything looks like. Now let's start talking about anemias, and we're going to start by talking about iron deficiency anemia. Iron deficiency anemia is the most common anemia that you will, for the most part, see in your practice. Doesn't matter what age range you work with, you're going to see an iron deficiency anemia. And this would be a microcytic anemia. It would also be hypochromic because of the deficiency of iron. The most common etiology of an iron deficiency anemia is actually blood loss, especially chronic blood loss, because with chronic blood loss, that blood loss over time, initially the individual can keep up with red blood cell production, but over time they'll deplete their iron stores and they will develop an iron deficiency anemia. However, we should also consider whether or not there's a malabsorptive process. So are they not absorbing iron in the GI tract? You may see this in Crohn's disease. You may see this in some individuals who have had gastric bypass surgery. In some cases, it's due to the specific procedure they had, or it may be due to diet, and they're not taking in sufficient iron in their diet. Another thing to think about, should have mentioned it in blood loss, it's not outrageously common, but if you have someone who has extremely excessive menstrual flow, you may see iron deficiency anemia in a female, especially if you couple that either with a growth period in their life, like during a pregnancy or some, not during pregnancy, they wouldn't have menstrual flow, but if you, an adolescent who has just experienced menarche, or if you have someone with pathology in the reproductive tract and they have very heavy uterine bleeding. You also want to consider an iron deficiency anemia in children during rapid or increased growth periods. As a result, then, you would want to especially watch for this in the 6 to 24-month-old, as well as during adolescence. So those would be your peak times when you'd look for an iron deficiency anemia in children. So in order for us to determine how that iron deficiency anemia may manifest in our lab work, we look at our iron studies. Incredibly helpful, not only in ruling in an iron deficiency anemia, but also ruling out other forms of anemia. First thing we're going to do is an iron level. Remember, 70% of iron is in our hemoglobin molecule, so do an iron level. We would also do a ferritin level. Now, remember, ferritin is telling you about your iron stores, and it tells you about the availability of those iron stores. However, ferritin is also an acute phase reactant. Because it's an acute phase reactant, which is an inflammatory indicator, you have to use it in caution in individuals who have an acute or either an acute inflammatory process or a chronic inflammatory process going on. So, for example, when you look at that ferritin level, let's say that you're looking at this in someone who has rheumatoid arthritis. In rheumatoid arthritis, they have a chronic inflammatory process, and so their ferritin levels may be elevated simply because of the arthritis, as opposed to really telling you whether or not they have available iron stores. So you have to put it together with their iron level itself. One of the other very useful iron studies is the iron binding capacity. And the total iron binding capacity tells us whether or not the proteins are available to bind the iron. Now, the iron binding capacity is increased in an iron deficient state. The capacity is increased because, for lack of a better phrase, they have room for more iron on the protein. Now again, that capacity can be decreased in inflammation. It also could be decreased in malignancy. Last but not least, the iron binding capacity could be decreased if the individual doesn't have sufficient copper in their diet, because copper aids in the uptake of iron into the red blood cell itself. So the total iron binding, if someone has an iron deficiency anemia, they would have a low iron level. Presuming they are not inflammatory, they would have a low ferritin level, and they would have a high iron binding capacity. Thalassemia is also a microcytic anemia. Thalassemia is the most common genetic defect in the world. And this is a genetic defect. It is an autosomal recessive disorder. And this autosomal recessive disorder, actually it's a group of disorders, is further classified by the type of hemoglobin. Hemoglobin A has two primary chains. It has alpha chains and beta chains. The beta chains are then further divided in, when we think about pathology, we think about thalassemia beta major and thalassemia beta minor. So what happens here, and the most common of this is actually the thalassemia beta. It's the first one we knew about it. when someone has thalassemia beta, they do not make enough beta chains in the hemoglobin A. When they make insufficient beta chains in that hemoglobin A, you actually have an imbalance, and then there is a higher amount of the alpha chains as it relates to the beta chains. When you have a higher amount of those alpha chains there, those alpha chains precipitate in the red blood cell, causing the red blood cell to become unstable and then hemolyzes, because that instability causes that premature destruction or the hemolysis. Now, I mentioned that there are two designations of thalassemia, the thalassemia beta. It has both minor and major. Thalassemia beta major is the most severe form of this disease and frequently requires transfusion therapy for homeostasis. The difficulty with the transfusion therapy, and this is not only with, it's anyone who requires frequent transfusion, is hemosiderosis. Hemosiderosis is increased iron storage in the liver and actually causes liver dysfunction. And when you think about thalassemia, I will tell you that in some textbooks they include thalassemia because it's a group of disorders. They actually include it along with sickle cell disease. So you may see it discussed in a couple of different ways, but it's not a sickle cell anemia. It's its own disease process. The second most common type of anemia overall, now remember, iron deficiency anemia, the most common type of anemia you will see. Thalassemia was the most common genetic disorder and causes a microcytic anemia. Anemia of chronic illness is overall the second most common anemia behind iron deficiency anemia, but anemia of chronic illness is normocytic. Anemia of chronic illness is secondary to a variety and a fairly long list of chronic illnesses. It can be due to chronic infection, chronic inflammatory states, and pretty much any long-standing chronic illness. It occurs at all ages and is pretty common. Now, in a number of these individuals, initially their anemia of chronic illness is just that. It is normocytic, normochromic. However, as this anemia becomes increasingly long-standing, they may become iron deficient simply because they're unable to use their iron effectively, remember that hepcidin, or they're unable to absorb the iron effectively. So as a result, you may see some iron deficiency in about 25% of the individuals with anemia of chronic illness. What we look for in the anemia of chronic illness is a decrease in the iron if they are iron deficient, but the ferritin level may or may not be helpful because remember chronic illness and the pro-inflammatory state. A lot of times in an anemia of chronic illness, because of the internal environment, the red blood cell actually tends to have a shorter lifespan. So when you look at an anemia of chronic illness, think about a normocytic, normochromic anemia, and that's why, as we talked about initially, in someone who has chronic kidney disease, they may begin with the anemia of chronic illness, but they become iron deficient as it becomes longer and longer. Or if we treat their anemia with erythropoietin because they don't have the hormone, we can actually stimulate an iron deficiency anemia because we're asking their bone marrow to produce a lot more red cells, but they have already depleted their iron stores. Let me know if that didn't make sense, but the idea here is anemia of chronic illness is normochromic, normocytic, frequently secondary to anything that can cause a chronic inflammatory state or chronic infection. Watch them carefully the longer it goes because they may develop an iron deficiency anemia because they've depleted their iron stores. Another type of normocytic anemia is hemolytic anemia. With a hemolytic anemia, you're looking at the destruction of red blood cells, and this is frequently due to either genetic, autoimmune, or could even be an adverse drug reaction. So if this is a genetic hemolytic anemia, could it be an Rh incompatibility? If it's autoimmune, you'll see this in some individuals with a rheumatoid arthritis. You'll see this in lupus. You may, and in adverse drug reactions, we see this in an abnormal response to synthetic erythropoietin sometimes. When you have someone with in which you suspect a hemolytic anemia, remember this is normocytic, look for hemoglobin in the urine and look for jaundice and the associated elevated bilirubin levels, because you're breaking down those red cells and you're overwhelming the liver's ability to process the bilirubin from that breakdown. You will also see a decrease in the haptoglobin. Haptoglobin binds to free hemoglobin, which then would be from those red cells being destroyed. Bilirubin, because it's made from, comes from the breakdown of those red blood cells and has to be processed by the liver, tends to be increased, as well as intracellular contents from the red cells may be elevated in the circulation. So you may see an elevation in phosphorus levels. You may see an elevation in the uric acid level if there's a lot of hemolysis. And you may also see an elevation in the potassium level if there's a lot of hemolysis. Now, as we talked about earlier, we talked about newborn jaundice, the newborn hyperbilirubinemia. It is a hemolytic process, but not an anemic process, and it should resolve within 1 to 2 weeks of birth. That's why you want to see your newborns within the first, usually about 5 days of birth. So what is aplastic anemia? Well, I mentioned aplastic anemia earlier when I talked about thinking about bone marrow function in general. Aplastic anemia presents as a pancytopenia, not just as an anemia, even though we call it aplastic anemia. You'll see the anemia, you generally will see the anemia first, and then you will also, as you see that pancytopenia, you'll also see a decrease in the white cells and the platelet counts. Generally, aplastic anemia is a disorder of stem cells. And this could be congenital. This could be due to chemotherapeutic agents. We've basically turned off their bone marrow through our chemotherapy. This can be due to a viral infection. Hepatitis can do this. Or it could also be autoimmune. Now, because we are talking about the function of the bone marrow, the only way to diagnose an aplastic anemia would be through bone marrow biopsy. So what about sickle cell anemia? Sickle cell anemia is the last of the normocytic anemias we'll talk about. Sickle cell anemia is one of the specific disorders that's included in sickle cell disease. When we talk about sickle cell disease, we use that as an overarching constellation of abnormal hemoglobins, primarily this hemoglobin S. So in sickle cell disease, someone may have hemoglobin anemia. They may also have the sickle cell trait. In order for an individual to have hemoglobin anemia, they must have 2 defective autosomal recessive genes. These autosomal recessive genes, in any autosomal recessive disorder, you have to have 2 genes in order to get the disease. So they get 1 defective gene from mom, 1 defective gene from dad. If they only have one defective gene, or one abnormal gene, I'm sorry, I really shouldn't call it defective, should I? One abnormal gene for hemoglobin S, they would have sickle cell trait, and they would then be a carrier of the disorder. So then sickle cell anemia is a genetic hemolytic anemia. It's estimated that in the U.S., about 1 in 500 African Americans has hemoglobin S, or has abnormal hemoglobin. So this is normocytic, normochromic, because it's not about the iron. Now when we talk about the incidence of this disorder, 1 in 500 in African Americans, the incidence of sickle cell anemia and sickle cell trait is much, much higher in sub-Saharan Africa. When we think about sickle cell anemia, remember this is a hemolytic anemia, and the red blood cells have hemoglobin S, which is not a normal hemoglobin. What that hemoglobin S does is it changes its shape, especially when it enters or is exposed to a low oxygen environment. The normal biconcave shape of the red blood cell of someone with sickle cell anemia, when it's in a low oxygen environment, changes its shape and it sickles because it has abnormal hemoglobin S. Generally, a sickle cell crisis, and these are, is an exacerbation. In a sickle cell crisis, there has generally been some sort of trigger, and that trigger can be infection, it may be dehydration, it may be hypoxia. This often presents as a vaso-occlusive crisis because those sickled cells, those abnormally shaped cells, can't pass through the capillaries the way they are supposed to. That abnormal cell keeps them from moving the way they are supposed to. That's why the most common presentation of a sickle cell crisis is acute pain, frequently in the joints. You will also see potential pulmonary infiltrates, and this can cause an acute pulmonary injury. We also know, because of these abnormal size and structured cells and the vaso-occlusive crisis, there is an increased risk during the sickle cell crisis for stroke as well as MI. The largest population where we see sickle cell crisis is in children and in young adults. However, we are beginning to see sickle cell crisis more in middle-aged adults as well. Partly because, I think partly because of our efforts and our ability that children with sickle cell anemia are able to survive longer and recover from a crisis. The last type of anemia we will talk about are the macrocytic anemias. The two we will talk about are B12 and folate deficiencies. And it's important that you be able to differentiate between these two anemias. When we look at a B12 deficiency, this is pernicious anemia, and it is a macrocytic normochromic anemia. What happens in a B12 deficiency, the individual is either unable to absorb B12 or they don't have enough B12 in their diet. If they have a difficulty in absorbing B12, one of the things to think about is whether or not they lack intrinsic factor. Intrinsic factor, which is in the gastric mucosa, is essential for the absorption of B12 from our diet. As we get older, in our 6th, 7th, 8th decade of life, our gastric mucosa produces less of this intrinsic factor. Now, you might imagine then, if there is disease of the gastric mucosa, you may also, or disorder of the the mucosa. You may also see difficulties with vitamin B12 absorption. This may happen in Crohn's disease. Now, Crohn's disease is a small intestine disorder, but you may see this because of a chronic inflammation of the mucosa in the GI tract. Again, you may see this in gastric bypass surgery patients, depending on which procedure they had done. So what about dietary deficiency? Vitamin B12 is especially present in animal protein. As a result, then, what population would be at risk for a dietary deficiency? Yeah, people who are strict vegetarians, people who do not take in any animal proteins. And you'll also see this kind of on a continuum of someone who is a vegan or is heavily vegetarian, eats primarily a plant-based diet. They may need to supplement their diet with exogenous vitamin B12 because their dietary sources are very low. Again, generally, unless someone is a strict vegetarian, you'll find a B12 deficiency as we get older. So then what we look for very simply is a level of B12. We check their cobalamin levels. Pretty straightforward. Now, what micronutrient then do you think we might need in order to produce the red cells and use that B12? Cobalt, absolutely. So we also need the cobalt to facilitate using that B12 in our diet. It's also important to consider B6 because B6 actually transports B12. A couple of other things that we can check. We can check the methylmalonic acid. That tends to be increased. Methylmalonic acid is part of our citric acid physiologic cycle. And we would also look at homocysteine. Homocysteine levels are increased in a vitamin B12 deficiency because homocysteine actually metabolizes methionine. And again, cobalamin assists in the synthesis of cobalamin. So then how does a vitamin B12 deficiency manifest? The big thing to watch for is paresthesia, because vitamin B12 is necessary for nerve cell conduction, and it frequently manifests as numbness and tingling, generally in the extremities. The individual may also present with a very red, beefy-looking tongue, and because of nerve cell dysfunction, may complain of some balance issues. So vitamin B12, you think about the ability to absorb vitamin B12 deficiency with that anemia, normochromic, macrocytic, excuse me. We're unable to absorb B12 either because we don't have an intrinsic factor, or it may be because we have a dietary deficiency, more likely in elders, and one of the ways we usually pick it up is through complaints of paresthesia. Folate deficiency is also an important macrocytic anemia. This macrocytic anemia is usually due to either, once again, a deficiency in a diet or poor absorption. Now, the poor absorption is more likely to occur in elders or in individuals who abuse large amounts of alcohol. As a dietary deficiency, it is possible because folic acid is in fruits and vegetables. Now, we know, however, that folate is very commonly added to a lot of foods. What's very important to remember about folate deficiency is that folate or folic acid plays an essential role during pregnancy in fetal development. In the presence of folate deficiency during pregnancy, the fetus is at risk of a neural tube defect. And so that's why we do a lot of folic acid replenishment and support during pregnancy. There are also some drugs that could compete for folate in the red blood cell, in the binding of folate in that red blood cell. Aspirin actually competes for folate in red blood cell binding. So again, small amounts of aspirin you don't have to worry about, but what if you have someone who takes a large amount of aspirin? Someone with rheumatoid arthritis who uses a fair amount of aspirin for pain control. So just kind of keep that together or in your mind. Now, what's a little frustrating about folate deficiency is that unlike vitamin B12 deficiency, there aren't a lot of symptoms, no big signal symptoms that we would pick up. There's no paresthesia. So it's something that we would pick up during evaluation for other problems. So we've talked about a lot. We know that anemias occur across all ages and across multiple disease states, and we've talked a lot about those. We talked initially about variations in those normal hemoglobins because we want to be sure that we consider that in addition to the pathologic variations when we're reviewing those red blood cells. It's important that you be able to, and we be able to differentiate the type of anemia by looking at the characteristics because those characteristics provide clues to the pathology of the anemia. In the microcytic anemias, remember we're talking about iron deficiency, we're talking about thalassemia. When we think about our normocytic anemias, we're going to think about the anemia of chronic illness. We'll think about sickle cell anemia, aplastic anemia, acute blood loss and hemolysis. With a macrocytic anemia, the most likely are going to be folate and B12 deficiencies. Although, as the chart indicates, you will also see this in alcohol abuse, partly because of a B12 deficiency. I hope this has been helpful in sorting things out. As always, please let me know if you have any questions. Thanks for your attention.